Hello, and thank you for joining us for today's program on reining in diabetes costs using plan design now and post-COVID. This event is part of the SHRM webcast series. You can learn about upcoming and on-demand programs from our e-newsletters and the webcast homepage at shrm.org/webcast. SHRM thanks today's sponsor, the Diabetes Leadership Council, for making this program available to the HR community. Now, a little bit about today's program. Diabetes is one of the most common and expensive chronic conditions in your workforce. It's been exacerbated by the COVID-19 pandemic. Today, you'll get ideas on how to handle your health plan designs to maintain a healthy, productive workforce and rein in your diabetes costs. To moderate our program, we are pleased to welcome George Huntley. He is a founding member of the Diabetes Leadership Council and currently serves as CEO of both the Diabetes Leadership Council and its affiliate, the Diabetes Patient Advocacy Coalition. Mr. Huntley, the floor is yours.
Mike, thank you very much, and welcome to everybody. Really appreciate you spending your hour with us, both good morning and good afternoon, depending upon where you are. A little bit more about the Diabetes Leadership Council. We are a 501c3 patient advocacy organization dedicated to access and affordability and health equity on behalf of patients and people living with diabetes. Personally, I am a patient living with type 1 diabetes since 1983. I'm a past national chair of the board of the American Diabetes Association, and also in my other day job, I'm the chief financial officer of Theoris Group, which is a professional services firm based out of Indianapolis, Indiana. And in that role, I have been the plan administrator of a self-insured health plan for over 20 years. So I have the health plan perspective as well as the patient perspective as we go forward. And again, thank you so much for spending your hour with us, and hope we have I think we have some great content for you and some good speakers. As advocates, we educate key decision makers and influencers, and that's part of our role today. Just about half of America is covered through employer health plans, as you probably are aware. So this audience in particular is of particular interest to us because you have key roles in the health of America and certainly the health of people with diabetes. So our goal for today is to understand how diabetes impacts employees and drives your health plan and your costs, and also to hear from some experts on ideas on ways to rein in those diabetes costs within your plan. And I think if you're living in Indianapolis today, it's pouring rain, so reining in costs is an appropriate thing for us to start with. The agenda, we're going to walk through this in 3 steps. We're going to start with an overview of the state of diabetes care and coverage, grounding everybody on what is diabetes and how is that being cared for today. We're then going to talk about marketplace dynamics that are influencing care and costs, and specifically in the pharmaceutical side of the benefit plan. And then we're going to close with a dialogue with some real-world examples on tangible steps to you to consider for your plans, and that will rein in diabetes costs and frankly improve your people's health. So without further ado, state of diabetes care and coverage. So first and foremost, diabetes is an epidemic. It's an epidemic, pandemic, it's going across the world. COVID's a pandemic. Diabetes was a pandemic and an epidemic beforehand, and it's certainly going to be one afterwards, and it's been exacerbated by COVID. 1 in 8 Americans and 1 in 8 adults in America have diabetes. That's 12.5% of the adult population, but those 12.5% are driving 25% of the healthcare spend. So it's a disproportionate spend, and diabetes is expensive. So that's probably a shocker to you, but we start with the obvious and we'll build from there. So the question is, why is diabetes expensive? And now you all get catastrophic claims list. Many of you do. I know in my plan, I get a list of catastrophic claims, and I shudder when I look at that list because it's got people who I care about on there, and it's got a dollar figure that scares the heck out of me. That's why they call it the catastrophic claims list. But on that list, you'll see heart disease, open heart surgery, stroke. You'll see end-stage renal disease. You'll see all of these things, amputations, but you will rarely see diabetes. You will rarely see that this patient has had diabetes for the past 10 years, and that is really the contributing factor, if not one of the drivers, as to why you're seeing those catastrophic claims. The good news is that you can prevent or delay these serious complications of uncontrolled diabetes by controlling diabetes, by investing in the management of diabetes. Diabetes, the cost of complications far outpace the cost of management. This is a disease where you can pay me now or you can pay me later. And far too many plans that we encounter are trying to cut costs in the management side of the house, and they're not realizing the impact they're having on patient health and really on their plan costs on the other side of the stream. So a little bit more about what is diabetes. Diabetes is high blood sugar. The question is, how did you get it? Type 1 diabetes, that's the type I live with, 5 to 10% have type 1. That's the small fraction. It's an autoimmune disease where my immune system has attacked the pancreas and destroyed insulin-producing cells, beta cells within the pancreas. I can't make insulin. Insulin is the hormone that allows the blood sugar to be released into the cells so that the body gets fuel. The muscle gets fuel, the organs get fuel. Insulin is critical in releasing that blood sugar. Otherwise, you basically starve to death, even you've eaten everything in your refrigerator, because the sugar and the fuel just gets stuck in the bloodstream. Type 2 diabetes is the most prevalent type. 90 to 95% of people with diabetes have type 2. It's somewhat autoimmune, but it's really a metabolic syndrome. You're making insulin in many cases, in most cases, but you're not using it well. You're resistant to it. It's deficiency. There's a deficiency in it. It's important to note that it's a progressive disease. And 1 in 3 adults in America with diabetes are in fact on insulin, even though when you look at type 2, that used to be the non-insulin dependent type. But 1 in 3 adults today are actually on insulin. So we talk about insulin and the costs and the issues, and we talk a little bit later on that. Remember, this is your type 2 population in addition to your type 1. And because of the resistance, the type 2 is using more than the type 1 in many cases. The other piece to understand here is in the type 2 population, about 1 in 5 don't know they have it. There's a huge undiagnosed population. So if you look at your population of employees, your wellness and your screening programs are very important because you could have people walking around not knowing they have diabetes, and they are the ones most at risk for the very devastating and very expensive complications. And finally, but not last, is the disproportionate impact that diabetes incident rates have on communities of color. And here on the slide, you can see that communities of color have between a 56% and a double rate impact than non-Hispanic white communities in getting diabetes. So your employee demographics may drive the number of people with diabetes you have in your company and on your plan, and will drive your overall costs. And as you think about your outreach with wellness messaging, with your HR messaging, your benefit messaging as a whole, are you reaching out to all of the populations that you really do need to reach out to? So I wanted to start with that as a backdrop. And now that I've got that backdrop, I'd like to introduce Dr. John Anderson to provide a medical perspective. John, as he's turning on his camera and microphone, John Anderson practices internal medicine and diabetes at the Frist Clinic in Nashville, Tennessee. He has served as president of this multi-specialty clinic, chair of the Department of Medicine, and chair of the board of trustees for the Centennial Medical Center. John is a past national president of the American Diabetes Association and a definite diabetes expert. John, I'm delighted to have you with us. Thank you so much for being here today. And I would just ask you, welcome you, and please share with the audience a bit about your clinic's diabetes practice and approach to diabetes care and how that impacts things.
Great, George. Well, I'm part of the Frist Clinic is an HCA facility clinic. So we have like 37 physicians and providers endocrinologists, GI specialists, but we have about 17 internal medicine specialists, and we all take care of our patients with diabetes. Now, because of my expertise and what I've served, I see more patients with diabetes than the average primary care provider would. I would say that I see 22, 23 patients a day, and at least 7 to 8 of them will have diabetes.
That's quite a number. And so how often or how long are you able to spend with these patients?
Well, that's the problem, because you're in busy practice. You have to see your patients. I will get 12 to 15 minutes with each patient. Now, we tailor that, right? So if a patient needs a little more time, we spend a little more time. Some of these patients may be very stable and not need to be seen nearly as frequently. But remember, I see this patient 12 to 15 minutes every 3 to 4, sometimes if they're really stable, 6 months. This really is a self-managed disease. One of our jobs as providers is to empower these patients to know what they need to know from a dietary and a lifestyle standpoint, to understand their medications, to understand the disease so that they can manage it. And, you know, I can't do that by myself. We've talked a lot in the American Diabetes Association about this team approach, right? Certified diabetes educators, dietitians, PharmDs. We need to use the community resources we have to empower these patients.
And I appreciate getting that message out, because I completely completely agree. And let's talk a little bit about the types of treatments that you're seeing today and where things have come from that regard.
George, it is staggering how far we've come. I started practice in 1989. I had 2 oral agents of the same class, and I had 2 older insulins. That's it. We have now expanded, especially in the type 2 world. We have newer medication classes. There's GLP-1 receptor agonists, DPP-4 inhibitors. All of these agents have revolutionized how we take care of people with diabetes. We have better monitoring devices. You know, there were not too many years ago when you had a urine test tape to tell what your glucose was in your bloodstream. We now have finger stick glucoses. We also now have what's called continuous glucose monitors, where in real time you can see not only what your glucose is at the time, but also its trend over the last day and where you're headed. We also have newer and better insulins. These insulins are much more physiologic than what we used to have. And as a result, you see patients have less low blood sugars because the pattern is more predictable.
I'm a living, breathing example of that. So I'm a big fan of the new technologies and the new drugs that are available. Just talk briefly on challenges that your patients and your practice might be experiencing from an insurance perspective.
I'd be happy to, because, you know, I have patients who are wealthy and don't have any concerns, and I have patients who struggle for every medication they have to pay for. And one of the things that we struggle with is this cost at the pharmacy window. Some of these newer agents, for example, the SGLT2 inhibitor class is associated with a 30 to 40% reduced risk of hospitalization for heart failure. Other GLP-1 receptor agonist classes, reduced cardiovascular disease. You talked about that cost, George, about the complications, and yet we're trying to take money from the management of it. Well, one can certainly monetize a 30 to 40% reduction in a hospitalization for heart failure. So for many of my patients, I know the medications that they need. I know which medications are ideal for them. I know that if we're not just in a silo of pharmacy benefits management, but we look at global cost, that this is the way to go with our patients. So we struggle with that. Sometimes cost is the issue that drives our medication choice. And far too often in our Medicare population, we see that too. But we also see this in our commercial population. Sometimes the medication is covered, but the copay is too high for the patient to afford it.
Yeah, and thank you, John. And we're going to be touching on that topic a lot today. I know we've got a really quick program here. I really do appreciate your being with us and sharing your perspective. And thank you so very much.
Thank you, George. Thanks for having me.
Much appreciated. And we're going to move on now, and I would like to, it's my pleasure now to introduce Marissa Town. Marissa is a good friend also. She's based in Cincinnati, Ohio. She's a BSN RN nursing degree, also a certified diabetes care and education specialist. She's been living with type 1 diabetes for over 30 years, has a passion for helping families living with type 1 diabetes and diabetes as a whole. Marissa's worked in clinical diabetes care at an insulin pump manufacturer. She's worked as a clinical research manager for the artificial pancreas research team at Stanford University. In addition to her Stanford work, she's also currently the clinical director for Children with Diabetes, which is a nonprofit that focuses and provides truly unique support for the whole family of people with diabetes. There's curriculum for the kids, their siblings, the parents, and their grandparents. If you have anybody in your community with type 1 diabetes and are dealing with issues, Children with Diabetes is a group to look up. So Marissa, thank you so much for being with us today. We just heard from Dr. Anderson about some of the treatment issues and what's going on. You've got a more personal perspective in addition to your strong professional credentials. Help us understand what a person with diabetes needs in order to be successful.
Yes, thanks, George, for the introduction. And I just, as someone who has lived with diabetes for a long time and then dedicated my life to helping other people living with diabetes, as the slide demonstrates, and as I can tell you, diabetes affects every single thing in people's lives that live with it. So when I sit down and I think, oh, I'm hungry, what can I eat, right? I have to make about 3 or 4 decisions. I have to know what my blood sugar is. I have to know how much insulin I have. I have to count the carbohydrates in that meal. Oh, and what if it has too much fat and protein? And every decision is made with all of these different layers, which really adds just a lot of work. So the more that we can do as people that work in healthcare or people that work to help people get insurance coverage for things to make people's lives easier, the better the management is going to be. And unfortunately, it's not A plus B always equals C equation. So people that are very think in black and white have a really hard time with this, because I can take, for example, the same amount of insulin for the same breakfast food 3 days in a row and have different blood sugars afterwards because of all the other things that affect blood glucose levels. And that's difficult. So what do we need to be successful? Well, as John mentioned, we need accessible and affordable healthcare tools. We have amazing technology. Right now, I'm wearing a continuous glucose monitor that I get my blood sugar on my Apple Watch. I mean, it is a great time to have diabetes in that regard. But one of the biggest barriers that people with diabetes are having from using these tools is cost. And as someone living in Ohio right now, and we're on my husband's insurance and he's a contractor, my insurance coverage is really not great. So I'm paying a lot of money out of pocket. I'm paying about $2,000 every 3 months just for the sensors for my CGM and the equipment that goes with the insulin pump to hook it up to my body to use it. And that's not even counting the insulin, which I'm paying $99 because of a manufacturer's coupon per vial. And I need about 1.5 vials per month. So I'm lucky that I have set aside this money to pay for just my health care. And I really have experienced that type of cost for most of my adult life. When I was working at Stanford full-time and living in California, I had the opportunity to have Kaiser Insurance, which is a little bit of a different model. It's an HMO versus a PPO. But really, they focus more on prevention and keeping people healthy. And it was incredible. I went to the pharmacy and I got 6 vials of insulin and I didn't pay anything. And I walked away thinking I had robbed a bank, that they were going to send me like a $6,000 bill. And I get home and I cry to my husband because this is literally my life source. And he looks at me and he says, Marissa, this is like you paying for oxygen that you need to live. And I had never thought about it that way. And it was very poignant, but I had never had the amazing experience of just having access to these tools without having to pay so much out of pocket. And I didn't have to pay for my sensors, for my pump supplies. And it was such a relief because what tends to happen is I'm having to spend a lot of time, a lot of mental energy focusing on how to get my tools that I want for my diabetes, because it makes my life easier and it makes my blood sugars in better control, which will give me better outcomes, make me a better mom, make me a better nurse, make me a more productive worker. And now, and in California, you know, on that insurance, I didn't have to spend all that extra time calling my insurance, asking why they're not covering these things for me. And it was just really incredible. And again, you know, these are things that, for me, these are the tools that work for me. But I am me, and my diabetes is different than George's diabetes. And for him, he might need something else. And not everybody wants to wear an insulin pump, and that's okay. But there are other options like smart pens, and, you know, having access to continuous glucose monitoring for all types of diabetes, or flash glucose monitoring for type 2 as well, or less intensive therapy needing people with diabetes. It's just amazing. I mean, when you go to sleep at night and know that something will be keeping you safe after you've exercised during the day, like imagine that you exercised, right, which you're supposed to do to stay healthy, and then you're worried because in the middle of the night, your liver is going to start doing this glycogen restore to give your glucose stores back into your body, and then your blood sugar is going to go low. And I'm so fortunate that I'm using this insulin pump and continuous glucose monitor that will lower my insulin automatically when it does that. But if you're taking one shot of basal insulin a day, or if you don't have a continuous glucose monitor to give you an alert when you go low, you know, it's scary.
So this technology is beneficial. It is not, and it is personal. Technology is personal. One size fits all. I really appreciate that. One other point I wanted to cover, and we're going to move on, but really great perspectives, is technology works. So having the right tools, and what you're seeing on this screen is the benefit of CGM, the continuous glucose monitoring. Regardless of what your insulin delivery method is, the far right hand, the red box, the A1C levels are lower, and this makes sense. This makes sense. It's when you're in business, what gets measured gets managed. And in the case of blood sugar, if you measure it, you're going to manage it a lot better. You're giving feedback to the patient. So, Marissa, thank you so very much for being with us. I really appreciate you sharing your time today.
Thank you.
So I'm going to move us on to a section on marketplace dynamics that are influencing our diabetes care and costs. And a lot of this is going to be in the pharmaceutical side of the healthcare plan. Now, this first part in the pharmaceutical side, 90% of the transactions are generic. 90% have no rebates. They're generic drugs, and that's a 2020 study. So that's very recent information. You can't read the small print on the screen, so I'll read it for you. The only thing I would say is, as you're looking at generics, and in specific with diabetes, and you're thinking about your plan, one of the most common drugs for type 2 diabetes is metformin. Many of you on the call will understand or recognize that drug's name. Metformin, you can buy at Walmart today for $3.77 for a month's supply. So for $3.77, you can go buy metformin. If your plan charges a minimum copay of $20 or $25, you are effectively marking up that drug 500 to 600% on your patients, on your plan participants who are paying a premium to access your plan. So as you look at that, talk through to yourself, you know, what do you really want to have happen there? And your metformin and your patient who has access to the internet, who has access to these things, are going to be aware that they're paying 500% of the cost of that drug. So be aware of that in your plan. 10% of the transactions your plan are in a branded drug, or a branded or a specialty drug. These drugs have rebates. We're going to talk about a little bit more about that. But the impact of these rebates is that they inflate list price, right? They inflate the cost of the drug itself for your patient. And more companies are now looking at passing those rebates through to their plan participants. And this study, 75% of Cigna clients, and this information came out about 2 weeks ago, so this is a very recent study. 75% of Cigna clients are passing the rebates through at point of sale, so during the deductible period. So that's something for us all to think about. And I'm now going to move us into a poll. And hopefully a poll is popping up where, does your organization offer at least one plan with full full rebate pass-through, excuse me. There you see it. So the answer is yes, no, or not sure. And if you don't know, and it's okay to not know, I would encourage you to go look. All PBMs today will offer a plan with full rebate pass-through. The big three, Express Scripts, CVS Caremark, Optum Rx, they all will have one of these plans, but it is not the one they will necessarily lead with in their dialogue with you. So as you think about that, you may have to ask for it. My company, Theorist Group, we offer 100% pass-through, and we've got, at our maximum, we had about 400 lives. So we're a small company, and we were able to negotiate full rebate pass-through for our people because it's important for their health. And this is very interesting. So only 13% are currently passing through, offering a plan with rebate. Hopefully by the end of this presentation, some of you will be moved to look at that a little more closely, and the 49% that don't know. And this isn't surprising to me. This isn't surprising to me at all, but I would encourage you to please look at this as we go forward. So let's talk about some other marketplace dynamics. Now, there's some numbers on this screen, and there's no footnote. And the footnote is the source for these numbers is George buying insulin in Indianapolis, Indiana in February of this year. So I went to CVS, and I had to refill my insulin prescription. Theorist allows a full rebate pass-through, so I paid $85 per vial. I bought several vials. The list price, the retail price, per the CVS receipt was $334. So that's roughly $250 of rebate that is built into this drug that I was protected from because of the plan design that we have. If I was not, I would have, let's say I bought 2 vials of insulin, that would be $500 of rebate that would have actually gone through to the plan. So if you're self-insured like we are, that would have gone through to the company. The company would have kept that $500 that I paid at the cash register during my deductible, and they would have used it to keep the rest of the plan costs down. You would have kept the employee, the premiums for the rest of your employee base down. But what's happening is it's reverse insurance. The sick, the person with diabetes, is in fact subsidizing the healthy. And that's not how insurance is supposed to work. And it's not really the value when I'm paying a premium for insurance. I don't expect to actually be paying for everybody else's claims in a starker way that I would have been doing. But also when you talk about what's not working the way it's supposed to work, let's look at how competition is working and the driving of the prices. So insulin as an example, and this is true of any drug, but let's use insulin, all right? There are multiple brands. There's at least 4 providers of insulin in the U.S. market today, and there's more coming on the market. There's biosimilars, not generics. There's one generic, and I'll touch on that in a second because it's a false flag. It's not real. But there is competition. There's competition for every class of insulin out there. So as competition rises, prices typically drop. And that's actually been true. Net prices have, in fact, dropped. The net price of insulin has dropped over the past 10 years. However, the list price on the far right side has gone through the roof exponentially because the pharmacy benefit managers who are managing your drug formulary are charging market access fees that in order to get onto your formulary. Now, those market access fees are going back, that's the rebate, they're going back through to you, but the list price is just being jacked up by the impact of those negotiations, which have gotten higher and higher and higher. Patients that are exposed to list price, we're looking at 1 in 4, and this is not just for those exposed, 1 in 4 patients reported rationing their insulin. That's a lot. And if you've got patients on your plan that are rationing insulin, that's a really bad place to be from a risk profile and exposure perspective. And this list price game creates a perverse incentive. It creates a perverse incentive that makes the pharmacy benefit manager more inclined to accept the drug that has the higher list price and the higher rebate than that lower cost drug. As an example, Eli Lilly, to pick on them, they came out with a generic of their own insulin, and they cut the list price of that generic in half. The formularies didn't pick it up because there wasn't enough rebate in it. The net price was nearly the same, but it's the rebate game that's in there because the pharmacy benefit manager is taking a slice of those rebates. And the folks that really lose in this game of list price are the uninsured because they have no option but other than paying list price or going to a manufacturer's program. So now let's talk about the benefit structure and what does that do to the monthly cost. And you can see that those stark difference between $0 and $1,200. That's your insulin. You've got all kinds of supplies, CGMs. If your patient is paying $1,200, that's a lot of money and you're going to lead to rationing. A person with diabetes is one of the highest risk profile people on your plan. You all understand that. You will give away apples in the lunchroom when you're allowed to, when we can all get back together and have a community lunchroom. There'll be apples in your lunchroom. You'll give out pedometers and T-shirts for healthy living and lifestyle. But your plan design could be training the person with diabetes to be non-compliant, to ration their medication. And you're raising the risk profile of the one demographic on your plan that you really want to lower the risk profile on. In addition to this, most people with diabetes are going to meet their deductible. Almost 100% of the time, a person with diabetes is going to meet their deductible. So if we are inflating a cost that they're paying, the plan isn't really getting the benefit of that rebate and that savings. They're actually going to pay another claim prematurely that you otherwise would not have paid. So there's another false economics in there as we look at this. So again, pay attention to what your plan is doing and what you're exposing a chronic disease management patient to. Now let's a little bit more on rebates. I used to call them manna from heaven. As the plan administrator 10, 12 years ago, I would have a meeting with our third-party administrator who's helping adjudicate our plan, and I'd get a check for $25,000. And I was having a bad month, and here's $25,000, and we're a small company. That was real money to us. So I wanted to hug the guy. I mean, you are my new best friend. Here's $25,000. Thank you very much. The one thing I did not have a clue of is should it have been $30,000? Should it have been 23 and he did such a great job, I got 25? I had no earthly idea whether I'm getting the right amount. And to this day, most companies don't. And this chart actually shows this. This is a 2019 survey by Kaiser Family Foundation. It's transparency is missing. You're not getting an audit report. And when you don't know what you're getting in there, it leads to uncertain cash flow, poor understanding, the perverse incentives we just talked about, and lower trust in the plan. If I am an employee and I'm paying a premium out of my paycheck to you for access to your plan, and I am paying full list price, why am I paying a premium? I can pay full list price without paying a premium. I know that there's a lot of other things that go along in a health plan, but it's food for thought as we think about things moving forward. I'm going to move quickly past this one. CVS Caremark came out with a RX0 where they literally said giving away diabetes medications, not just insulin, would save the plan money, $2,000 per person that's going from non-adherent to adherent status. The plan saves money if you lower that reimbursement rate or lower that cost. I now want to introduce Erica Hedberg and Geoffrey Bound. If some of you saw the pre-meeting information, Robin Richardson was scheduled to be part of this presentation, and unfortunately Robin's had a family emergency. But Erica has been very gracious to jump in at the last minute, and I'm thrilled to have her. And Jeff, if you could be turning on your camera now. Let me introduce the two of them very briefly. Erica Hedberg is the Director of Government Accounts at Moda Health, a regional health insurance provider covering the Pacific Northwest. She joined Moda in 2015, has worked collaboratively with large government accounts on coordinated care models and benefit designs that support members in their health. Prior to that, Erica has worked for the state of Oregon in various areas, including the Oregon Educators Benefit Board and Health Policy. And she has her master's degree in public administration with a focus on health administration from the Portland State University. And delighted to have her with us. Also, Geoffrey Brown. Jeff has been in health benefits for his whole career, including 20 years as a consultant with Mercer, 7 years as a consultant with Willis Towers Parent. Willis Towers Watson, forgive me on that. He is the current chair of the Oregon Educators Benefit Board, which is a benefits exchange providing health care coverage to school districts and local governments in Oregon, and it covers nearly 165,000 lives. So Erica and Jeff, thanks so much for joining us today. I'm really appreciate you spending your time. I'm going to ask Jeff to start it off, but I want you, the two of you, to just collaborate with this, because I know you've got and established a collaborative relationship in creating a chronic care model that I really do want and shared with this audience, and I commend you all for it. So thank you for being here, and Jeff, take it away, and Erica, chime right in.
Great, thanks, George. Before I start, I want to just say that George picked diabetics, or those that are living with people with diabetics. I've been a type 1 for 36 years. And I echo Marissa's comments. I would add one more to it, that earlier I've experienced criticism in essence because of having different reactions to the food that I eat, and essentially people tend to think that you must not be managing yourself well if you have highs or lows. But the new continuous glucose monitors really help moderate those swings, so they're extremely helpful. The Oregon Educators Benefit Board was formed in 2007. I'm going to give you a very brief background. And it was intended to create an exchange to provide benefits to over 200 school districts in Oregon. Each of those school districts contain 3 to 5 different represented or non-represented groups. So all in all, there's over 1,000 different discrete groups represented under this board. Currently, OEB offers a choice of 10 different medical plans, 3 HMO models, 5 dual choice preferred provider type organizations, including a community care managed model, and a couple of high deductible plans. When OEB was formed, it was given a number of directives, and the 3 that are most relevant today is that OEB was charged to gather and evaluate data, to be creative and innovative, and improve employee health. In carrying out these directives, we quickly observed in the data some interrelated conditions: obesity, diabetes, and musculoskeletal conditions. So to address these conditions and to take a deeper dive, OEB formed a subgroup, a work group, that in separate meetings dove deeply into the data. And on that work group were about 4 board members, representatives from the insurance companies that we contracted with, their medical directors, our consultants, and staff people. And so what we did was to dive deeply into the data, discuss with our carriers what possible solutions there were, establish some goals, ask our carriers to partner with us. So everybody was on an equal footing there in that group. And what emerged were cooperative medical directors. I think that was really unique in that the carriers were no longer competing. They were helping us solve the issues. And over time, we have introduced a number of programs. Some of them have been replaced by successor programs. But what I thought we might do is talk about 4 distinct attributes of the plans we offer today. They are incentive co-payments for office visits and prescriptions for members with certain chronic conditions. We have a comprehensive coordinated care program for high-risk members that fit in those categories. And now we offer a choice of a coordinated care model network that really directs patients, members, to primary care with incentives to those primary care providers to help patients manage those their conditions. And then we have preferred co-payments for insulin and other diabetic programs. So at this point, I want to ask Erica to lend some details to those 4 areas.
Yeah, great. Thank you, Jeff. And, one thing I just want to echo before I dive into the programs is that it really has been a collaboration between the carriers and OEB. And we really have worked together over the years, like Jeff said, to look at the data and really discuss and dive deep into how we can better serve and support our members. And so we have been able to be pretty creative with some of our solutions. And so one thing that Jeff mentioned is that we do have a coordinated care plan. And this is something that has evolved over the years. And the coordinated care plan really directs members to establish a relationship with a primary care provider. And not just any primary care provider, but it's really steering members towards high quality primary care providers. And they're called patient-centered primary care homes, or PCPCHs. And these are primary care providers who are certified by the state of Oregon as having met certain levels of care and offer certain benefits to their members, such as having 24-hour access to the providers. And so we really steer our members towards those providers. And when members do select one of those PCPs, they get incentivized with lower co-payments and cost sharing, so that we're really trying to reduce the barriers to members being able to access care. So they get co-payments to be able to see a primary care provider and a specialist that are not subject to the deductible. And then the primary care providers are incentivized to provide good quality care. And one way we do that is by giving them capitated payments in addition to regular fee-for-service payments. And the providers can use these payments to help support different ways to support members. So they can bring in a behavioral specialist into their clinic, or they can hire a case manager who can work with members outside of just that traditional fee-for-service visit, where they may only get a few minutes to work with their provider. So we've continued to evolve that coordinated care model, and we'll continue to evolve it as we look into the data. Something else that we've added to our benefit plans is the incentive care office visit. And this is a reduced copayment for chronic care conditions, which diabetes is one of them. So members get a reduced copayment, not subject to the deductible, to see their PCP and their specialists. And when we first rolled out this benefit, we only had it apply to the primary care provider office visit. But when you think about members, especially with diabetes, they also need to have oftentimes relationships with a specialist, such as an endocrinologist. So by also applying the lower copayment to the specialist, it's helping, again, reduce that barrier to being able to access care for members with chronic conditions. And it's not just for diabetes, it's for other chronic conditions such as heart disease. And the reason we do this is because the diabetics I know oftentimes do not just have diabetes, but they also have other chronic conditions that also need to be managed. So we're really looking at reducing the barriers for members to be able to access care for all of their chronic conditions. And a program that I'm really excited about that we implemented back in 2014 is the Comprehensive Coordinated Care Program that Jeff discussed, which we call C3, or those 3 Cs. And this program identifies our highest risk members with chronic conditions, and we reach out to them and we help them get connected to one of those high quality primary care providers. And then we actually waive the copay for these members for primary care office visits and as well as mental health office visits. And then we also give them access to our advocate team. And this team includes health advocates, registered nurses, and health coaches. And so members can access this health coach or this advocate team when they need some additional help, because we know that the healthcare system can be complicated and things can happen in between office visits. So this advocate team is there to help members and guide them to being able to solve some issues, such as if a prior authorization for a pump is held up, with a provider, and really just kind of being able to work through some of those administrative issues that can really cause a lot of frustration for members. And the last program that I'll discuss really quick, because I'm sure we have to move on, is Livongo. And Livongo is something that we just recently rolled out to OEB. And it's a diabetes management program that provides members with a smart connected glucose monitor, as well as unlimited testing supplies at no cost to the member. So members can order their testing supplies right from an app, and those supplies get delivered to their doors, and the member pays nothing for those. And what's great about the connected meter is that it's recording all of their readings and sending it to Livongo, and as well as their primary care provider and their and family members that they identify. And when there is an out of range reading, it actually sends a notice out to those members and their selected family and providers, letting them know of that out of range reading. And in addition, it also helps members understand what the numbers mean, and then also help provide them guidance on how to respond to high or low readings. So it's essentially helping diabetics be the best diabetic that they can be. And then members also get access to health coaching that's available 24/7, and they can work with those health coaches through phone, email, or text messaging. So really just kind of breaking down the barriers to being able to access care and coaching when they need it. So that's just a sample of some of the programs that we've rolled out around diabetes. Jeff,
Thank you so much for sharing that, Jeff and Erica. I really do appreciate this. There's a lot of time and energy and research and insight went through this. I will say, the one thing as a commentary, folks in the insurance world and folks dealing with 165,000 lives and a dozen plans or more, Jeff, they tend to be pretty good at math. So if you're seeing an ROI for some of these things, it's one of the reasons I wanted to share and have the audience hear some of these plan design issues and some ideas.
So Georgia, trying to measure an ROI when you have a disease that is multifaceted, there are complementary programs. So overall, I think what we're looking at is what's the outcome for the plans. And I can say two things, is that all of these programs are effectively incentive programs. So we haven't reduced benefits for anybody anywhere else, and we've tried to attract people into these relationships. And the second thing I'll say is that our 3-year average of price increases is less than 3%. So we're really seeing a positive influence on the group as a whole.
That's an impressive statistic. So I am going to have to move us along in the presentation, but I really do appreciate both of you being here and sharing your stories with the audience. And I'm going to wrap because we're getting close to the end here. There's a couple of questions out there, but I got a couple more slides I want to get us through. But thank you both so very, very much.
Thank you.
As we go. We've had this on the screen while Jeff and Erica were speaking. Plan features for you guys to consider on your plans. Pre-deductible coverage. First and foremost, diabetes management is preventive. Move the costs pre-deductible. Along that same theme, low predictable employee cost sharing, so that you're not hit with a spike or a shock bill at CVS that would, or Walgreens or wherever you're buying it, that would cause you to start being not adherent to your therapy. Passing through rebates, that is something that more and more companies are doing and are looking at it. It's eliminating reverse insurance, and it's beyond diabetes. It's every drug out there on your plan has this. And the person with chronic disease, you are better off having that person with chronic disease actually take their medications and take care of themselves than ration it. And that's a key plan design area that could help impact that. Treatment choice. Marissa touched on it. Access to what the patient needs. This is a not one-size-fits-all disease. The insulin pumps, the continuous glucose monitors should be what the patient needs, and not one-size-fits-all where you're dictated to have this or that. You're not told what car to drive. You have a budget for it, but you're not told what car to drive. It does make a difference for that patient. And I'm going to move us quickly to another poll, which says, does your organization offer at least one plan with first dollar coverage, preventive coverage, pre-deductible for chronic disease management? And hopefully Mike can put that up there super. So if you would take a second on this. When we had conversations on this, and some of you may not even know if you offer first dollar coverage for chronic disease management, and I would urge you to find out, again, if you don't know. But there was questions prior to 2019 in a high deductible health plan. You said, well, I'm not allowed to. I have to include this as part of the deductible period. But that's actually since been clarified about 18 months ago by the IRS. Chronic disease care can be pre-deductible in a high deductible health plan. And it was because many, many, many employers were asking for it because it was costing them so much money to have the chronic care paid, pay me now, pay me later. So it is absolutely allowed to be treated pre-deductible. We as patient advocates encourage you to treat it pre-deductible, but it's a may, not a must. So we want you to want to do it. So here we have it, 30% roughly are doing it, 40% are not doing it, which we encourage you to look at. Another 30% aren't sure. And that's a good, honest approach, and I urge you to just go back and look. I've got a couple more points I want to bring up that we haven't touched on, or maybe we touched on briefly in here. So win-win scenarios, continuity of care rather than annual medication changes. This is the area called non-medical switching. This is where once a year, the pharmacy benefit manager decides they're going to change this drug or that drug, and this SGLT2, this insulin, whatever it might be, and now the patient's got to switch. Your plan, when that happens, you are taking a stable patient with a chronic disease, and you are moving them to a less stable state. And as a patient advocate and as a business person, that does not make a lot of sense. In most instances, the net price that you're paying for those two drugs has not moved at all, but the rebate has, and the pharmacy benefit manager is taking a slice out of that rebate. So you've got to look hard at that scenario. Rapid adjudication for diabetes-related claims, specifically when someone has been diagnosed with diabetes or is now being progressed and they need insulin. That is a really bad time to implement step therapy. If a patient needs insulin, they need insulin. They need insulin now. It's a really bad time for step therapy. And let the doctor practice medicine, especially in scenarios where you've got employees joining you that have already been on those other drugs that you may have designed and may have denied. Now you're making them take a step backward. And the same would be true is in gestational diabetes. If someone is a woman in her third trimester is now told to go on insulin, she doesn't have 60 days to go through an appeal process. So take a look at what you're doing and how your plan handles those issues. Cover diabetes care and education as needed rather than capping it. Diabetes is a 24/7, whether it's type 1 or type 2, all of those things. We have 42 factors impacting blood glucose. It doesn't care whether you're type 1 or type 2. Those factors are in play. Education is essential, and you'll allow your employees to go through multiple smoking cessation plans and programs, and you hope that they'll eventually learn. Not many people make total lifestyle changes in their first go, so we encourage you to not limit that. Avoid copay accumulators and maximizers. These are where the drug, there's a copay card on that drug, and in these types of plans, the insurance company will take the benefit of that away from the patient and pull it back to the plan, which effectively simply defers when the patient's going to ration. They're going to get the drug early because they've got the copay card. copay card is going to run out. Now they're rationing in the summer or fall instead of the first quarter in a calendar year plan. If there's no generic available, we urge you to take a really hard look at the value of those plans. We've talked about generics and spread. Insurance literacy, I do want to touch on. The materials that you have for a patient or participant with diabetes, does it share with them what's covered, what insulins are covered, what CGMs, what insulin pumps, what education, all of those support things, and are you making those educational materials during your open enrollment period back to your employee demographics, and are you getting them in a fashion that all of those demographics can absorb that information? So I urge you to take a hard look at that, because knowledge is power, as we all know. I'm not going to go through all of this from key takeaways, but and this information, the slide deck's up on the SHRM site as well as our website. Hospitalization claims, if you're paying more on hospitalization and absenteeisms, then you're doing it wrong. And those are areas where you can really save a lot of money, but you got to make some investments. So again, I thank you so much for being with us, and we have precious little time for Q&A, but I do hope you've gotten something out of it. Mike, are there questions out there that we can tackle real quick?
Sure. Let me. Let's try and squeeze in just one or two questions. We know folks need their research information. We'll get that to you in just a moment. Let's just see if we can get a couple of these in. Audience member asks, what percentage of non-adherent diabetics become adherent when a value-based plan is introduced?
That is an outstanding question. I don't have a stat for you. I can tell you anecdotally that a patient that suddenly has access to doctors, has access to the things they need to manage their disease, they feel better and they're going to have a better health result. And usually that's enough motivation to move them. They may need some more education around with that, but I don't actually have a stat for you on how many move. But if they didn't move, that CVS RX0 stat where they were showing a $2,200 savings and an overall break even for the plan at worst, that shows you that it's not going to cost the plan money. It's going to actually save money and improve health.
Audience member writes, I want to educate our workforce about the risks of diabetes. What kind of symptoms should they be on the lookout for? Are there resources you can recommend to help get out the message?
Absolutely there. It's an excellent question as well, because again, 1 in 5 are not diagnosed. They're walking around with the disease and don't know it. The American Diabetes Association has a risk test profile on their website. There's a ton of information on the symptoms of diabetes, thirst, lethargic. You can have mood swings. It impacts people in different ways. So some people might get the classic one is excessive thirst. You're drinking a lot and you're going to the restroom a lot, frequent urination, headaches, again, lethargic. But there are scenarios where a dentist will see it because you can't fight an infection. Eye doctor may catch it by doing a retinal exam. But for just basic symptoms, there are some very basic questions that you could include in any of your employee benefit newsletters and wellness information.
All right, thank you. I hate to cut us off, but we do need to wrap up here. SHRM thanks the Diabetes Leadership Council for sponsoring this program and SHRM's series of free webcasts. The Diabetes Leadership Council is a 501c3 patient advocacy organization. Its members, all former leaders of national diabetes organizations, engage policymakers and public and private sector influencers to secure effective, affordable health and a discrimination-free environment for every person affected by diabetes. To learn more about the Diabetes Leadership Council employer initiative and health plan designs to meet the needs of patients and payers, go to diabetesleadership.org or email info@diabetesleadership.org. Also, our presenters are asking if you have a moment to fill out a survey they've made available. The number is on the screen. The web address for that survey is on the screen right now. It's also in the PDF of the program if you downloaded that. It is tinyurl.com/DLC-webcast-survey. Before we sign off now, though, we do want to thank some folks. First, our great presenters today, George Huntley and Dr. John Anderson from the Diabetes Leadership Council, Marissa Town of Children with Diabetes, and Erica Hedberg from Moda Health, and Geoffrey Brown from the Oregon Educators Benefit Board. Thank you all for the insight you provided us with this program. And we also want to thank everybody who tuned in today for being with us and for choosing SHRM for HR webcast. That concludes today's program.